Assalamu alaikum. Good morning. Welcome to the third day of the conference. Alhamdulillah, as you saw, the previous 2 days were very busy days till the late evening. Alhamdulillah, all the people were interactive, and we have various very scientific content. And we are honored with your presence and your participation and your interaction that made the conference more and more fruitful. I'm honored with your presence, and I'm honored to introduce my dear friend and colleague, Dr. Bassam Dia. In this conference, I intended to have all colleagues together from all facilities in UAE, aiming that we are one hand and we are together. And this Congress is for all UAE, not for any separate entity or any person. All of us, we love UAE and we are working for it. And of course, this is the country that we love and the country that give us all the opportunities and chances to excel. So the least to do is to thank our beloved country and to do our best to serve the country. That's why I intended to have all our colleagues together. And I'm very thankful for Dr. Bassam Dia for mastering the ceremony today. Dr. Bassam Dia is a specialist psychiatrist at Dubai Academic Health Cooperation, core faculty member for psychiatry, postgraduate training program, and a board member and media and cultural chairperson of the Emirates Mental Health Society. Please join me welcoming Dr. Bassam.
Good morning, everyone. Thank you, Dr. Madhat, for the beautiful presentation. Good morning, ladies and gentlemen. It's my pleasure to welcome you all to the third day of the World Psychiatric Association Congress titled Innovation in Treatment and Psychosocial Rehabilitation. This event presents a fantastic chance for networking with both domestic and foreign colleagues. As supporting the development of current connections or forming new ones, as well as innovation and learning experiences. This conference is accredited by the European Accreditation Council for continuing medical education for 17 European CME credits, and the program has been awarded a maximum of 25 CPD credit hours by the World Psychiatric Association. Also, we need to mention the help for making this conference a reality. So we appreciate your participation and important contribution of our partners and sponsors. To mention them, Lombic as the diamond sponsor, Janssen platinum sponsor, Asino the gold sponsor, Heckman as a gold sponsor, Spimaco bronze sponsor, and Exceltis as bronze sponsor. And of course, not to forget the conference exhibitors, ProPharma, Medical Supplies, and Reem Hospital. So, as I think you may already know from the previous days, this conference consists of 3 tracks. Track 1 will be held in this hall, Dar al-Istiqbal, and the coming session will be chairperson by Dr. Hawra Sajwani, and track 2 will be in the auditorium in the lobby floor, and the chairperson will be Prof. Mumtaz Abdul Wahab, professor for psychiatry in Cairo University, president of the Egyptian Psychiatric Association, Qasr Al Aini, Faculty of Medicine, Cairo University, Egypt. And track 3 will be in meeting quarter 1 to 3 on the 3rd floor. And the chairperson will be Dr. Mehnaz Zafar, consultant psychiatrist and clinical lead community psychiatrist services in Amal Hospital. Okay, so I think we're just 5 minutes behind schedule. So without further delay, ladies and gentlemen, may I call your esteemed chairperson for session 7, which is next. And that will be Dr. Hawra Sajwani, who is I have the pleasure to present her as my friend and colleague. She's a consultant in addiction psychiatry at Sheikh Khalifa Medical City. She has 4 years of training from North America, from the University of Toronto and UCLA, and she has master's degree in addiction. So welcome, Dr. Hawra.
Good morning, everyone. And thank you, Dr. Bassam. So we are going to start with the 7th session of this Congress. We're going to have 3 talks. The first one will be on vocational opportunities and quality of life among persons with chronic schizophrenia under processes of disability law enforcement in Thailand. It would be presented by Dr. Kamanet Wanasawok. And then the second one would be updates on the management of bipolar disorder by Professor Tariq Hokasha. And the last one will be on the future of children's mental health by Professor Tammy Benton. So I'm delighted to be presenting the first speaker, Dr. Kamanet Wanasawok, who is an associate professor of psychiatry at the Department of Psychiatry, Faculty of Medicine, Sri Raj Hospital, Mahidol University. After obtaining a diploma from the Thai Board of Psychiatry in 2006, she received the opportunity to participate in the Yongan Mental Health Fellowship Program of the WHO Collaborating Center for Psychosocial Rehabilitation and Community Mental Health in the Republic of Korea in 2007. In 2019, she graduated with a Master of Rehabilitation Counseling from the University of Sydney in Australia. She was an invited speaker in several conferences, and she's an author of a chapter in the Advances in Psychiatry textbook. Moreover, she is a member and secretary of the WPA section on psychiatric rehabilitation. This track is going to be virtual, so we're going to start the lecture, which was pre-recorded, and then in the end, we will have the question and answer session. You may start it now.
Sawadee ka. Hello, ladies and gentlemen. My name is Dr. Kamanet Wanasawok. First of all, I would like to thank you for WPA to provide me an opportunity to share all of you about vocational opportunities and quality of life among persons with chronic schizophrenia under processes of disability law enforcement in Thailand. I have nothing to disclose. This session I have aimed to demonstrate the auxiliary mechanism to promote employment for people with disabilities in Thailand. And I will describe the characteristics of Thai people with mental and behavioral disabilities due to schizophrenia working under disability law to promote vocational opportunities. In Thailand, we have total number of population around 66 million people. When considering the number of people registered with disability, there are more than 2 million people, which is equal to 3.26% of general population. In Thailand, we categorize the category of disability into 7 categories. The first is physical and mobility disability, which almost half of people with disability are in this category. The second one is hearing and communication disabilities. The third one is vision disabilities. The fourth one is mental and behavioral disabilities. The fifth one is intellectual disabilities. The sixth is learning disabilities, and the last one is autistic. The people with schizophrenia are included in type 4 and category 4 of mental and behavioral disabilities. We all know that the employment rate of people with schizophrenia are much lower than the employment rate of people of general population. In Thailand, we have only one study who study about employment rate of people with schizophrenia, and it was found out that less than 50% of people with schizophrenia have were employed. When compared to the employment rate of Thai general population, which almost 100% of people were employed last year. And when considering in the global level, the general population around the world have employment rate around 75 to 80%, but the people with schizophrenia around the world have very low employment rate. Only 16 to 23% got a job, got a paid employment. So in Thailand, we also have a legislation or policy to promote vocational opportunities for people with disability. We have Empowerment of Persons with Disability Act since 2007. The main section that related to the job or occupation for people with disability have 3 sections. The first is section 33. The employer and establishment must employ 1 person with disability per every 100 employees in their companies. But if they decide not to employ, the employer or establishment must pay to the Fund for Empowerment and Quality of Life Improvement of Persons with Disabilities at minimum wage rate for every day in a year. The last one is section 35. If employer or establishment decide not to employ, they must support persons with disabilities in other aspects, such as providing space for a business or of persons with disabilities, or providing facilities and any support for the disabled person. When considering the information have got from statistics in June 2022, there are 58% of establishment, or the organization in the private sector that choose to employ persons with disabilities, and 19% of them choose to pay to the fund and not hiring people with disability, and 23% of establishment provide support or job opportunities for people with disabilities. In Thailand, if people with schizophrenia would like to get a job, especially a job that set aside for people with disability, they have many ways to request for assistance. The first is they can contact to their psychiatric hospital directly that they receive treatment. If social workers or a staff in psychiatric hospital have a connection directly to the government agency or establishment that require to employ people with disability, they can help people to get a job, or they might walk into require assistance from the service center for people with disabilities in the province to apply for a job, or they might can walk into the employment agency in the province to request a help for applying a job. This they can contact each other if they require assistance from other organization. Or people with schizophrenia can apply to train to develop their vocational and skill in training center in their area. This training center not set aside for people with disability. So anyone who would like to develop their skill can apply to join the program. At the end of the day, a person with schizophrenia maybe end up to work with government agency or establishment that require to employ people with disability, or they may end up to be to self-employment or be a freelance. However, when I try to find the statistic or information about the percentage of agency that comply with the disability legislation section 33, 34, 35, I found something that I'm not happy. Considering establishment, or I mean in the private organization, almost of them comply with this law. Even though last year it dropped to 95%, but when compared to the public sector or government agency, I found out that the rate of law compliance are really tragically decreased from 43% in 2019 and reduced to only 15% in 2022. It might be because of there's no clear measure to enforcing the law among government agency. So, Social Innovation Foundation has been established since 2012 under financial support from Thai Health Promotion Foundation to promote employment for people with disability, because we found that they found that many government agency or establishment want to comply with the law, but they may not ready to take care of employee with disability, or don't know how to provide support for people with disability in their workplace. So Social Innovation Foundation step aside to be a matchmaker between the requirement of establishment to comply to the law and the requirement of public benefit organization or foundation or any association or disability club or disability service center that might need more workforce but lack of financial support. Social Innovation Foundation, the staff of Social Innovation Foundation will contact to the node or coordinator in each local area to matchmaker people with disability who want to be employed with the workplace in their local area that ready to provide support for workers with disability, and be a medium with the government agency or establishment to monitoring the work of people with disability. And so the government agency or establishment will pay the salary to the people with disability directly. It's a win-win situation because people with disability got a job, agency or establishment can comply to the law, and the public benefit organization has more workforce. However, in Thailand, there's no any information about employment situation of people with disability due to schizophrenia working under law 33 and 35 in Thailand. We have only total number of people with disability in working age group, which equal to more than 800,000 people, and more than half of them are not identify their employment status, and there is only 1/3 of them that were employed. We have only the number of people with mental and behavioral disability that being employed under law section 33 and 35, which only less than 2,000 people. And it's not specific only for people with schizophrenia. For people with schizophrenia, it's less than that. Thus, there is an attempt to conduct a research by Ms. Prel Iemnoi, who are a PhD student of Ratchasudha College, Mahidol University, to study about processes of law enforcement on vocational and earning opportunities and quality of life among persons with psychosocial disabilities due to chronic schizophrenia. She and her team aim to study the processes of disability law enforcement on vocational and earning opportunities for persons with psychosocial disability due to chronic schizophrenia. And she will examine the characteristic of employee with schizophrenia working under this disability law enforcement. So I have the part of her result from this study result to be to present for all of you today about vocational opportunities and quality of life among persons with chronic schizophrenia under processes of disability law enforcement in Thailand. The PhD project have studied about law enforcement on vocational and earning opportunities by using qualitative study and applying conceptual framework of the study according to the Consolidated Framework of Implementation Research, or CFIR. Ms. Prel Iemnoi have studied about characteristics of policy and legislation. And the second, she studied about inner setting and outer setting of the policy. And she also studied about the characteristic of individual or related stakeholders, which include policymakers, policy practitioners, people with mental and behavioral disabilities due to schizophrenia and their support network, such as their families and communities. So this part about people with mental illness and behavioral disability were studied by applying quantitative study to examine demographic and their functioning by applying short version of ICF 9 items to study about their functioning and study about their quality of life by using WHO quality of life brief questionnaire. The people who will that have been included in this study are people with mental and behavioral disability due to schizophrenia who were confirmed diagnosis by ICD-10 as F20 for more than 2 years. They must have disable ID card and they were in working age group, which means 18 to 59 years old, and they must working under section 33 and 35 and can communicate in Thai. We use Cressy and Morgan's formula to calculate sample size, and it's equal to 140. And we use multi-stage randomized sampling to collect data from the sample size from in each 5 regions of Thailand equally. And these are the results. Unfortunately, because of many limitations, we collect data from only 110 people, which equal to 78.6% of calculated sample size, and only Bangkok that we got the sample size exceeds the target. But other regions such as northern, central, and eastern part of Thailand, northeastern part of Thailand, and southern part of Thailand, we collect the sample size less than the target, which the list is from people with schizophrenia in southern part of Thailand, because the people with schizophrenia live scattered in this part of Thailand, and lack of officer or coordinator or who work with people with disability to help research team to collect the data. Okay, about demographic data, I will show you in 2 groups. Everyone must be people with disability due to schizophrenia who work under section 33 and 35. However, at that time of data collection, some may be unemployed because their program or their work program stop, or they quit from their job. More than half of sample size are male. In working in middle age, the mean age of them are around 42 and 43 years old. And most of them are single, live with their parents, and have got family support, especially moral support. And the highest proportion of the highest educational level are high school certification in the employed group, but in bachelor degree or higher in the unemployed group. When consider the information about history of mental illness and treatment, the mean duration of illness are 16 to 17 years, and majority of them have a history of psychiatric hospitalization. Most of them follow up regularly, and most of them have only oral medication. Most of them have right to reimburse medical expense with the main benefit health scheme is universal coverage, which are benefit health scheme that for every Thai citizen who are not a government officer or have social security by themselves. More than half of them report that they still have side effects, which the most is drowsiness. And more than half of them also report that they still have residual symptoms, which the most is cognitive impairment. When consider only the employed group, most of them have a history of receiving any rehabilitation, such as vocational rehabilitation, program to improve their self-care or social skill training. And 2/3 of them receive this type of rehabilitation from public organization. The top 3 rank of their current occupation are job at entry level and sales workers or service workers and craft in business. And they have got average income around $268 in a month. And they work almost 40 hours in a week for more than 2 years. They have more than almost 12 years of lifetime work experience. And most of them work under Section 35. When we assess the quality of life by using WHO quality of life brief, it was found that the score of quality of life in almost every domain of people who are currently employed have got higher score than person with currently unemployed, except for the domain of physical health that people with current unemployment have like higher score than person with current employment. And when considering their functioning by using short version of ICF used for assessing Thai people with mental and behavioral disabilities, it has 9 items to assess 9 functioning. The first is functioning to acquiring new skills, and conversation, watching oneself, looking after one's health, doing housework, complex interpersonal interactions, informal social relationships, acquiring, keeping, and terminating a job. And the last one is functioning to recreation and leisure. And each of these functioning, we can qualify or explain the magnitude of impairment by consider the percent of need of assistance to complete that function. Point 1 means no difficulty. It means that person no need to be anyone help them to complete that skill or that function. Point 1 means my difficulty. They might need a little help from other to complete their functioning in that part. Point 2 means moderate difficulty. They require some degree of assistance to complete their function. The point 3 means severe difficulty. They need assistance more than half of time to do their functioning. And the last one is point 4 means complete difficulty. They always cannot do that activity or function in that activity without assistance from others. When consider the top of functioning reported with no difficulty and with moderate to complete difficulty among Thai people with mental and behavioral disabilities. We found that for the skill that the highest number of response that there is no difficulty, the top rank of functioning is washing oneself, looking after one's health, and recreation and leisure. And for magnitude of impairment or activity difficulty that moderate to complete difficulty, it was found that functioning to acquiring new skill, complex interpersonal interaction, and acquiring, keeping, and terminating a job is the top 3 rank of functioning report that they have problems. So I can conclude that although Thailand has the Empowerment of Persons with Disability Act since 2007, which is a policy and legislation to promote employment for people with disabilities, the number of working age group of people with mental and behavioral disability due to schizophrenia who are employed under the law has been still low. Social Innovation Foundation and auxiliary mechanism to promote employment under Section 33 and 35 of the disability law has been established since 2012 to be a matchmaker between the need of establishment to employ workers with disability and the public benefit organization that need more workforce. The characteristics of people with schizophrenia who are employed under the law Section 33 and 35 were predominantly male, single, middle-aged, have a highest educational level at least high school, and live with their parents, and has also received family support, especially moral support. Their mean duration of illness was at least 16 years with a history of psychiatric hospitalization. Most of them received only oral medication and had also regularly follow up outpatient unit. Most of them had a healthcare scheme that was mainly universal coverage. More than half of them had still experienced side effects, the majority of which was drowsiness and also residual symptoms, that the majority of which were cognitive impairment. Majority of them had received any form of rehabilitation from public organization. Currently, they work at average almost 40 hours in a week for average 2.72 years with an average income of $268 per month. Most of them had worked under the disability law Section 35. And the top of their current occupation were the job at entry level, sales or service workers, and craft in business, respectively. People with schizophrenia who are employed tend to have a higher quality of life score than the unemployed group, except the physical health domain, but there were no statistical difference. The top of functioning report that there is no disability were washing oneself, recreation and leisure, and looking after oneself. On the other hand, the top of functioning report that there is moderate to complete difficulty were acquiring skill, complex interpersonal interaction, and acquiring, keeping, and terminating a job. Thank you for your attention.
Thank you, Dr. Vanessa Walk, for a very informative talk on the rehabilitation of schizophrenia patients. Our next talk is going to be on the updates on the management of bipolar disorder. And it is my honor to be presenting the speaker, Professor Tariq Ukasha. Professor Ukasha is a professor of psychiatry at the Institute of Psychiatry, Faculty of Medicine, Ain Shams University. He's the director of the WPA Collaborating Center in Research and Training in Psychiatry. He's the founder of the Psychiatry Unit at the Faculty of Medicine, Misr University and Technology in the 6th of October City, and a visiting professor of Psychiatry and Psychology Department, Faculty of Arts, Cairo University. He's the Secretary General and member of the Scientific Committee for the Evaluation of the Scientific Research presented for the promotion to the positions of Assistant Professor and Professor in the field of Psychiatry in Egypt. He is the recipient of the WPA Presidential Commendation and Honorary Fellow, an Executive Committee member of several national and international associations and organizations. He has published more than 55 papers in national and international journals, contributed in 14 national and international books, and supervised more than 50 master's and doctorate degree theses. Please welcome Professor Tariq Akasha.
Hello, everybody. First of all, I would like to say it's a pleasure to join the WPA Thematic Congress with the title Innovations in the Treatment and Psychosocial Rehabilitation. I would like to take this opportunity to thank Professor Medhat Sabahi for his kind invitation to join this meeting. I apologize for not being able to be there in person, but at least I'll be able to be with you virtually. I would also like to take this opportunity to thank both the scientific and organizing committees for putting such a strong and powerful scientific program for this WPA Thematic Congress. My presentation today will be about updating the management of bipolar disorder. First of all, when we talk about bipolar disorder, Farley, the French psychiatrist in 1851, was the first one to coin the term folie circulaire or cirques, and it was the beginning of the understanding of the bipolarity. Before that, we had Heinworth from Germany, who called it mixtures. Gresinger from Germany also called it middle forms, and Gosselin from Belgium called it mixed states. And it wasn't until 1899 when Kraepelin coined the term manic depressive insanity. As we're all aware that we have mood and affect. Before that, it was called bipolar affective disorder, but now it has been changed to bipolar mood disorder, since the affect is the external expression of mood, but mood is actually what the patient themselves feel. So, of course, it is better to have it as the term of bipolar mood disorders. We are all aware that in order to diagnose a manic episode, we need a duration of 1 week. For a hypomanic episode, we need the duration of 3 to 4 days. And for a depressive episode, we need 2 weeks in order to be able to establish a diagnosis. Bipolar disorder is not as easy as most people think regarding the diagnosis, because when we study bipolar disorder as undergraduates, we always see a manic patient who is elated and happy. But we don't know that bipolar disorder has multidimensional several forms. It can come in the form of mania, depression, hypomania, subsyndromal depression, mixed states, comorbidity with alcohol, comorbidity with substance abuse. So there are many forms for the bipolar disorder. Life prevalence or lifetime prevalence of bipolar disorder is higher than what we thought before. It is now estimated to be approximately 2.4%, which is even higher than schizophrenia. The 12-month prevalence rate of bipolar disorder is 1.5%. And bipolar disorder is one of the highest psychiatric disorders which can be transmitted genetically, and its heritability ranges from 70 to 90%. Also, bipolar 1 is both equal in males and females at a ratio of 1:1. However, bipolar 2 is more frequent in females than it is in males. We also have the prevalence of bipolar 1 to be 0.6% and bipolar 2 to be 0.4%, and the mean age of onset of the first episode of bipolar, whether it is a depressive episode or a manic episode, is between the ages of 17 and 25. Also, it is important to know that the first episode in bipolar disorder is usually depression, whether it is bipolar 1 or it is bipolar 2. Depressive episodes are common in both of them, as I mentioned, And the psychotic symptoms as delusions and hallucinations occur in nearly 75% of manic episodes. That's what makes it so confusing between mania, schizophrenia, and schizoaffective disorder. According to the World Health Organization, currently there are approximately 60 million people worldwide suffering from bipolar disorder. When we talk about morbidity and mortality, we usually talk about depression, about suicide, about schizophrenia, but even bipolar disorder has a morbidity. Patients who suffer from bipolar disorder lose 14 years of their work life or productivity because of the disorder, and it is considered the third leading cause of premature death in psychiatry after depression and schizophrenia. As mentioned, mortality is also high. There is a 9-year reduction of life expectancy in patients with bipolar disorder. We discussed before in several papers. In schizophrenia, there is approximately 10 to 15 years decrease in life expectancy. In depression, there's a decrease in life expectancy, but also bipolar, there is a decrease in life expectancy. What is interesting is completed suicide. It reaches a mean of 19% in patients with bipolar disorder and up to 50% attempted suicide. This is very important because when we teach our students, we usually tell them that 15% of depressed patients will commit suicide and double that amount will attempt suicide. But we never talk about suicide in bipolar disorder. And we have to remember that bipolar disorder is depression with occasional episodes of mania or hypomania. But the main presenting symptom is usually depression. And depression in patients with bipolar is stronger. It is more of an emotional turmoil on the patient because the patient has already known or tasted what mania and hypomania is. So when they drop into depression, the drop is very high and very steep. There are several risk factors for suicidal attempts. If the bipolar is comorbid with drug abuse, there is family history of affective disorders, the depressive episodes are severe or psychotic symptoms, early traumatic stresses in childhood, and comorbid psychiatric disorders. In a study in the United Kingdom, they found that death rates of 18% were reported for patients with bipolar disorder over a 35-year study period, and attempted suicide rates were varied between 21 and 54. So we can say that nearly 18 to 19% of patients with bipolar disorder will commit suicide and nearly 50% will attempt suicide. So it is very, very important while taking the history of the patient, examining the patient, to ask for suicidal ideation and put in our mind that bipolar disorder is mainly depression, not just the manic episode. Also in Italy, an Italian study reported 22% of males and 54% of females with bipolar I disorder had a history of suicidal attempts. In a French study, nearly 40% of bipolar patients had attempted suicide at least once. So we see that nearly 50% of patients suffering from bipolar disorder will attempt suicide during their life, which is a very, very high percentage. Eduardo Vita in Spain found that 38% of bipolar patients with a comorbidity had attempted suicide compared to only 21% with patients without comorbidity. So what are the risk factors for suicidal attempts in bipolar disorder? Being female, having a bipolar I diagnosis, being single or divorced, predominant depressive polarity, comorbid axis I diagnosis, family history of mood or suicide, previous suicidal attempts, and as mentioned before, childhood trauma and conflicts at home or work. This is an interesting slide which shows the psychotic symptoms in bipolar disorder. As we can see, nearly 50% of patients with bipolar disorder have auditory hallucinations. Another 50% nearly have delusions. 23% have catatonic symptoms. And the commonest presentation of catatonia is with mood disorders, followed by schizophrenia. And what is really interesting is approximately 8 to 10% of patients with bipolar disorder present with Schneiderian first-rank symptoms. We all know that Schneiderian first-rank symptoms are pathognomonic of schizophrenia, but this has changed. It's pathognomonic of psychosis. And that's why in the DSM-5 and the ICD-11, the use of the Schneiderian first-rank symptoms have been dropped because they're not specific for schizophrenia only, but specific for the psychotic symptoms themselves. There is a very high rate of misdiagnosis of patients with bipolar disorder, and several studies showed that nearly 70% of patients with bipolar disorder were misdiagnosed with another psychiatric disorder. The commonest psychiatric disorder misdiagnosed as bipolar disorder is unipolar depression, followed by other diagnoses such as schizoaffective disorder, schizophrenia, and so on. So the commonest misdiagnosis for bipolar is unipolar or major depressive disorder. In the United States, a survey found that nearly 30% of patients with bipolar disorder was diagnosed correctly in the first evaluation. That is, 70% were misdiagnosed. That's why the diagnosis of bipolar disorder is one of the most difficult diagnoses in psychiatry. Also in Spain, the same number, 30% of patients with bipolar disorder were given another diagnosis. The 30% were diagnosed correctly and 70% were given another diagnosis. And surveying more than 1,000 people with bipolar disorder, the mean time to a correct diagnosis is 5.7 years. So it takes a patient with bipolar disorder from 5 to approximately 6 to 7 years to be properly diagnosed. Very similar to patients with obsessive compulsive disorder who wait for 5 to 10 years in order to be diagnosed because they're unable to talk about their obsessions, especially if they have religious and sexual nature. There was a big study about bipolar disorder called the Bridge study in all countries, several countries in the world. This paper was taken from the Egyptian sample, and we found that while screening for patients with bipolar disorder, we found that the commonest misdiagnosis was unipolar disorder. Patients were diagnosed with unipolar disorder instead of bipolar disorder. And why was this mistake? This mistake was done because usually patients ask, or physicians and psychiatrists ask the patients about the manic symptomatology. They ask about the clear presentation of classical mania, but they forget that bipolar disorder also has hypomania, and nobody asks for the hypomanic symptoms that lasted for 3 to 4 days in order to establish a diagnosis of bipolar disorder. In this study, the hypomania checklist scale was used, and this hypomania checklist scale was translated and validated into Arabic, and can be used by all psychiatrists in the Arab world in order to pick up patients with bipolar disorder who are mistakenly diagnosed with unipolar disorder. In the sample that we saw, also nearly 60% of bipolar patients were diagnosed as unipolar mood disorder. Also, in another study in Egypt, we looked at the cognitive functions in euthymic Egyptian patients with bipolar disorder and looked, are they different from the healthy controls? We have cognitive symptoms in schizophrenia, we have cognitive symptoms in depression, but do patients with bipolar disorder also suffer from cognitive functions, distortion in cognitive functions? Is it in the depressive phase, the manic phase, and do they continue in the euthymic phase or not? In this Egyptian study, we found, yes, that there are cognitive deficits present in patients with bipolar disorders, even in the euthymic phase. The core feature of cognitive function in bipolar disorder is prevalent in nearly 65% during episodes and 57% during euthymic. The main affecting symptomatology include the attention, verbal learning, verbal memory, and executive functions. Some people have attributed this to the neuroinflammation that can occur during the bipolar episode, with increased levels of cytokines and chemokines, which may affect the brain and result in these disturbances that we see in cognitive functions. Bipolar disorder is a long-term disease and has several recurrences. In Spain, a study showed that a patient at the age of 40 has suffered more than 11 to 15 bipolar episodes, depending on the nature and the onset of the disease itself. Of course, as psychiatrists, we might look and talk to each other and say, a patient age 40 with 15 episodes of mania, hypomania, or depression, this is too much. Usually by the age of 40, we see 5, 6, 7 episodes. But please remember that in the Arab world, the patient only comes to the doctor or comes to hospital when it is a severe manic episode or a severe psychotic, suicidal, depressive episodes. Patients with hypomanic episodes that last for 3 to 4 days. Patients with mild to moderate depression might not even go to the physician themselves. But if we take into consideration all the mild depressive episodes, moderate depressive episodes, hypomanic symptoms, as well as the classical and severe manic symptoms and the severe psychotic and suicidal depression, we might see patients suffering from 11 to 15 different episodes. In a German study that followed up patients for 2.5 years, they found that only 27% of patients with free of symptoms, nearly 56% had recurrences. So bipolar disorder is a recurrent disorder, and patients have to be treated properly in order to prevent further relapses as much as possible. In Egypt, we had a few years ago a merge group, a group interested in mood disorders called Mood Disorder Expert Research Group in Egypt. And we published several papers. One of these papers was the role of the traditional healers in the pathway to care of patients with bipolar disorder. We found that patients went to traditional healers in Egypt with bipolar disorder exactly like patients with schizophrenia and depression, severe psychotic depression. This was attributed to witchcraft, it was attributed to jinnis, it was attributed to lack of faith, it was attributed to many things. So traditional healers were also the first line where patients with bipolar were visited. After that, they transferred to psychiatry. We should not forget also that bipolar disorder is also known to have a lot of comorbidities, whether they be medical comorbidities like migraine, pain, diabetes, cardiovascular disease, and obesity, or psychiatric disorders like personality disorder, ADHD, impulse control, anxiety, substance abuse, and so on. We conducted a study in Egypt about the correlates of psychiatric comorbidity in a sample of Egyptian patients with bipolar disorder, and we found, similar to the international literature, that the number one comorbid psychiatric disorder, axis 1, was anxiety disorder, and on axis 2, the borderline personality disorder. And in international literature, the comorbid psychiatric disorders were rated to be approximately from 31 to 75% of patients, with anxiety disorder being the number one cause, and followed by that, the substance abuse. And in the personality disorders was the borderline personality disorder. What is interesting that usually we don't ask about history of anxiety symptoms in patients with bipolar disorder. It seems it's important for us to ask. In 1992, during my residency, there were several papers that came out about discussing treating patients with manic episodes using clonazepam, which is Rivotril, giving 2 milligrams 3 times daily, which is 6 milligrams to control the manic symptomatology. Of course, some patients did not respond, some patients did respond. There are a lot of problems that occurred with giving high doses of benzodiazepines, but thinking back, the patients that actually improved were most probably the patients that had comorbid anxiety symptoms with their manic or depressive symptoms in bipolarity. So it is important also to look for personality disorders and bipolar disorder, and to look for anxiety disorder as well. This slide is an important slide, and I think the most important part is the last two lines. If you look at patients presenting with bipolar 1 disorder, we'll find that for each manic episode, there are 3 depressive episodes. So patients with bipolar 1 disorder spend more time in depression than they spend time in mania. However, in bipolar 2, it's even worse. For every 1 hypomanic episode, there are 30 depressive episodes. So now we can understand the point that I was trying to make earlier, that patients with bipolar disorder are patients suffering from recurrent episodes of depression with occasional manic or hypomanic episodes. That's why suicidal rates are high, and that's why the depressive symptoms are so strong and affecting the patient psychologically, leading to increased emotional turmoil, because of the patients who were able to, as I said before, taste what is hypomania, what is mania, and feel the sense of elation, of sense of euphoria the social disinhibition, the grandiosity. When they drop into depression, it's really severe. There are a lot of challenges in treatment of bipolar disorder, starting with the initial diagnosis, which are several presentations as difficult to diagnose, the comorbidity, whether the comorbid axis 1 psychiatric disorder or physical disorder, the presence of depression, the chronicity of the illness itself, and the phenotype of the disorder, whether it's bipolar 1, 2, mixed, rapid cycling, drug-induced, and so on. In Egypt, we had a study in the International Journal of Social Psychiatry, which was published last year, and we talked about the management challenges in patients with bipolar disorder. And there was actually no agreement on how to approach a patient with bipolar disorder, which mood stabilizer, which antipsychotic, whether to use antidepressants or not use antidepressants. So this was something which is a little confusing for people working within the field of psychiatry. Bipolar disorder is one of the few disorders in psychiatry that uses all the psychiatric pharmacology that we know. We can use antidepressants, anti-anxiety, antipsychotics, anti-epileptics, and mood stabilizers such as lithium. Of course, the main treatment of bipolar disorder is a mood stabilizer. So we always teach our students, once you diagnose bipolar disorder, the first medication that should be written is a mood stabilizer. After that, we can see the other medications and other symptoms. But an ideal mood stabilizer is a mood stabilizer that can work during mania or a manic episode. It can work on the psychotic symptoms in the manic episode. It can work on a depressive episode. It can work on the psychotic symptoms in a depressive episode. It can reduce the relapse prevention. It has favorable cognitive effects. It has long-term usefulness. It is safe and well tolerated. Do we have such a mood stabilizer? The answer is no. However, we try and have mood stabilizers and use them differently in order to try and get the best benefit from it. How can I say that my mood stabilizer is working? Whether I used an anti-epileptic, lithium, a second generation antipsychotic, how can I say my mood stabilizer is working? We have 4 things that can occur. Firstly, if the patient does not have any other episodes, that means that I have controlled the bipolar. Unfortunately, this is the least thing that occurs. The second thing is that if the duration between the episodes increases, so instead of having an episode every year, the patient says, now I have an episode every 3 years. So an increase in the interval or duration between episodes, or a decrease in the intensity of the disorder itself. Instead of suffering from manic episodes, they suffer from hypomanic episodes. Instead of suffering from severe depression, it's mild or moderate depression. And the fourth thing is that the patient does not need hospitalization. The patient is insightful enough to start treatment or go to the doctor before the severity of the symptoms that need hospitalization, and the patient can be treated on an outpatient basis. So these are the 4 things that can occur that can make me comfortable to say that my mood stabilizer is working. However, if none of these occur, then I have to either change or add on the mood stabilizer itself. These are all the different mood stabilizers available. We have the lithium, we have the carbamazepine, oxcarbazepine, valproate, lamotrigine. The gabapentin and topiramate are anti-epileptics, but their proof as mood stabilizers has not yet been approved. Before that, I mentioned benzodiazepines were used. Conventional antipsychotics can be mood stabilizers, but due to their severe side effects, they are not used. And we're aware that some second-generation antipsychotics can be used as mood stabilizers. And there's the issue of the controversial use of antidepressants in patients with bipolar disorder. Lithium is the classical gold standard mood stabilizer. Some people are not using lithium as they used to use it before for several reasons. One of them is that some people say that there are a lot of laboratory tests that need to be done with lithium, whether kidney functions, thyroid functions, serum level of the lithium itself. But we have to know that lithium at the moment, in all the literature that has come out over the past 5 years, that lithium is still the gold standard for bipolar patients suffering from either manic or depressive episodes. Of course, it has better response in patients with classical mania, some patients with depression. It has anti-suicidal effect, so should never neglect the effect of lithium. And unfortunately, lithium is so cheap that there is no drug firm that does any symposia or does any standalone meetings to discuss the importance of lithium. But we hear that about antipsychotics and antidepressants. So lithium is sort of like an orphan drug that has no one to care for it. But people who work in bipolar disorder know how important and how effective lithium is. The FDA has approved several drugs to be used during acute mania: lithium, carbamazepine, valproate, aripiprazole, which is a third generation antipsychotic, and some second generation antipsychotics, as well as the use of ECT. In Egypt, the word electroconvulsive therapy, we have changed it into brain synchronization therapy. Even in Arabic, instead of using electroconvulsive therapy, which is الجلسات التشنجية الكهربائية, we now use the term brain synchronization therapy, which is جلسات تنظيم إيقاع المخ, which helps to decrease the stigma about ECT. In acute depression, we have the quetiapine, lorazepam, cariprazine, and the combination of olanzapine, fluoxetine. Also, ECT can be used. And we come to the controversial use of antidepressants. A lot of people believe that we should not use an antidepressant in a patient suffering from bipolar disorder. I had the privilege to work in 1997 with Professor Jacob Akiskal in the International Mood Center in San Diego, and he used to also say, using an antidepressant in a patient with bipolar disorder will pollute the clinical picture of the patient, and you will not be able to properly diagnose the patient. Of course, we are all aware about antidepressant causing affective switches. Now, it is recommended not to use antidepressants in bipolar 1 patients at all. And if we need something with an antidepressant effect, we should use a second generation antidepressant with an antipsychotic with an antidepressant action. A second generation antipsychotic with an antidepressant action, like quetiapine, like asenapine, like lorazepam, like cariprazine, like a combination of olanzapine and fluoxetine. But if we have to use an antidepressant, we should probably use it with bipolar 2 rather than bipolar 1. Some people have said that the least one to cause switches is the bupropion. Some people have mentioned the agomelatine and some SSRIs. But if you are going to use an antidepressant, it's preferably not, especially in bipolar 1. But in bipolar 2, please use it with caution. In maintenance therapy, the FDA has approved lithium, lamotrigine, aripiprazole, olanzapine, quetiapine, and risperidone. And we have all the new second generation and third generation antipsychotics. Some of them have an antidepressant action, which can be used in the depressive phase of the bipolar, and some of them have strong antipsychotic action that can be used in the manic phase and can be used as add-ons to other mood stabilizers like lithium or anti-epileptics specifically. Of course, the anti-epileptics, lamotrigine is only indicated in the bipolar depression. Aside of the medication, we should never forget the psychotherapeutic techniques. One of the main asides of this behavioral therapy and cognitive therapy, social rhythm therapy is very important in bipolar disorder in order to get a rhythm that regarding the sleep-wake cycle of the patient, how the patient utilizes the daily routines of his life, breakfast, lunch, dinner, going out, playing sports, having a rhythm, because patients with bipolar disorder, when they disturb this rhythm, especially the circadian rhythm, it can induce an attack with the patients. Of course, you're all aware about the CanMat, which is used, one of the recent algorithms for the treatment of bipolar. We have it regarding the management of agitation. We have it in the treatment of bipolar disorder, and we see that quetiapine, lorazepam, lithium, lamotrigine are all present here. As you can see, lithium has green lights all over. Even if we look at the bipolar during the maintenance phase, we see how important lithium is. So use of lithium now is becoming very, very important, and understanding it and using it is important, because during the 80s and 90s, people moved away from lithium and moving back to it again now as the gold standard for the management of bipolar disorder. Even in hypomanic symptomatology, the use of anti-epileptics or even second-generation antipsychotics is important. To conclude, accurate and early diagnosis and delaying relapses are critical in the optimal treatment of patients with bipolar disorder. The goal of treatment should be complete symptomatic and functional recovery, because it is easy to achieve symptomatic recovery, but functional recovery takes a longer time. So our eye should be on the functional recovery rather than symptomatic recovery, since even residual manic and depressive symptoms may contribute to morbidity and mortality, as we discussed. Regularly monitoring both the benefits and risks of medication optimizes treatment outcomes. The development and validation of biomarkers for bipolar disorder may allow earlier diagnosis and guide treatment selection, which are goals of precision psychiatry. And we should always remember that once we diagnose bipolar disorder, a mood stabilizer has to be used, since the mood stabilizer is the most important thing for relapse prevention. Thank you very much for your kind attention.
Thank you, Professor Akasha, for a very rich talk on bipolar disorder. Our next talk is about the future of children's mental health. It will take a village. It will be presented by Professor Tommy Benton. Professor Benton is the Frederick Allen Professor of Psychiatry at the Perelman School of Medicine at the University of Pennsylvania. She is the Psychiatrist-in-Chief and Chair of Psychiatry at the Children's Hospital of Philadelphia and Chief of the Division of Child Psychiatry at the University of Pennsylvania. She's a Distinguished Fellow of the American Academy of Child and Adolescent Psychiatry. She is a member of the National Institute of Mental Health Advisory Council and the American Association's Council for Research. She directs the Child and Adolescent Mood Program and the Youth Suicide Center at Children's Hospital of Philadelphia. And she is the President-elect for the American Association of Directors of Child and Adolescent Psychiatry. Please welcome Dr. Benton.
Good morning. I'm Tammy Benton. I'm a child and adolescent psychiatrist at the Children's Hospital of Philadelphia, and it's a real honor to be able to join you today. Today, I want to talk about the future of children's mental health and what it's going to take to get us through the next few years. I have no financial disclosures. So I want to talk about this discussion about the future of children's mental health and what we're going to need to do to be able to address the need by providing you with some facts to anchor this discussion. So just thinking about the scope of the problem, there are close to 2 billion children in the world who make up about 30% of the world's population. And more than 13% of the adolescents between 10 to 19 years of age live with a diagnosed mental health disorder. That represents about 90 million adolescent boys and about 80 million adolescent girls. And we know that mental health conditions worsen over time, that about 86 million 15 to 19-year-olds are affected by a mental health condition, and about 80 million youth between the ages of 10 to 14. And unfortunately, the suicide rates continue to rise for young people between the ages of 10 and 19, with almost 46,000 ending their life approximately every 11 minutes, which is tragic. Some other key facts relate to the types of mental health conditions that impact young people. So anxiety and depression constitutes about 40% of the mental health diagnosis among youth, but it's also important to recognize that mental health conditions exist on a continuum, and so that some youth who are experiencing psychosocial distress also experience impairment. And while it's not disruptive, it should be a focus for intervention so that it does not become a disorder. We know that suicide is the 4th leading cause of death for 15 to 19-year-olds, and for girls, it's the 3rd leading cause of death. And worldwide, for 10 to 19-year-olds, it's the 5th leading cause of death. So despite all of our focus and interventions, we've not been able to turn this around. So it's also important to note that these mental health conditions are disorders of childhood. So that about 1 in 5 children and adolescents will have a mental health or behavioral health disorder. Their onset are pretty early. So about half of them will start by the time a child is 14, 75% by the time they're 24. And if you think about it, those are the most formative educational, developmental, and occupational years in a young person's life. We also know that onset varies by condition. So the neurodevelopmental disorders such as autism, ADHD start relatively early. Anxiety disorders have early onset. The mood disorders such as depression tends to have an onset around adolescence, but recently we've seen earlier onset for these conditions. And then schizophrenia, psychotic disorders, and substance use disorders tend to follow a course similar to adulthood. They tend to start in later adolescence. The pandemic has increased our attention and focus on children's mental health conditions. We knew they existed before the pandemic, but the pandemic has sharpened our focus. And what we've seen is really the tip of the iceberg. But if we learn nothing else, I think this quote is really appropriate. If it hasn't taught us anything, it's that our mental health is profoundly affected by the world around us. And so how did this mental health crisis that we're focused on right now begin? And most of us know it's been going on for a while, and what we're seeing is really the tip of the iceberg. But certainly environmental factors have exacerbated those things. So we've had much discussion about adverse childhood experiences over the recent years. And we know that adverse childhood experiences impacts mental and physical health outcomes. So physical, sexual, emotional abuse, neglect, parent-caregiver mental illness, community neighborhood violence or decay, and racism has been added as an ACE that impacts mental health and physical health outcomes for young people. But we know that discrimination or the perception of discrimination impacts the mental health of young people. And most of us know what the factors are that derail social and emotional development. So we know that poverty, poor living conditions are overrepresented among those who have mental health conditions. Exposure to trauma, community violence, stigma, exclusion, interpersonal violence, victimization and bullying, harsh parenting, neglect, loss of caregivers, lack of access to care, inequities based on gender, sexual identity, or migration status, disasters, war, and increasingly media influences. So there's been a much stronger focus on the impact of social media on young people's mental health. And all the data is not in. Some of it's positive, some of it's negative, but we have a lot to learn. We also increasingly recognize, particularly in the United States, that social and economic factors drive health for 90% of health outcomes. The healthcare system drives about 10%. But when we look across all the contexts in the United States, racism and discrimination are major factors. They impact economic stability, the quality of your neighborhood. We know that housing, transportation, safety, public spaces, and playgrounds are important for young people. We notice that poor health outcomes are concentrated by zip code and region, education, food security, social contacts, level of social integration, community supports, exposure to violence or trauma, community engagement. And then, as I mentioned, only about 10% of health outcomes are driven by the healthcare systems, which in itself can form barriers to mental health for certain populations. So what are some of the other factors that prevent young people from getting the mental health care that they need? Well, we know there are clinician shortages. So if we just look at the numbers of child psychiatrists in lower income and higher income countries, the average ratio of child psychiatrists to patient population of children is about 0.1 to 100,000 in lower income countries, about 5.5 to 100,000 in higher income countries. So even in higher income countries, the numbers are not sufficient. The wait times are long. There are geographical maldistribution, with most psychiatrists being located in cities, not out in rural areas. Poverty, stigma, bias and discrimination about mental health, and then knowledge gaps among the providers who are providing care. So despite the fact we have thousands of evidence-based interventions, many healthcare providers don't use them. And then there's payment and outdated, inefficient care models. We have opportunities to improve those care models and expand access. But despite what we see with the rising suicide rates for young people and the impairments in mental health, The median government expenditure is only about 2% of the expenditures for physical health, which I think speaks to a lack of awareness and commitment to mental health. We also know that mental health conditions among young people that include suicide is costly for us. And when we think about, payment power parity, in billions of dollars per year, it's estimated that we lose about $387.2 billion per year due to mental health conditions. And when we look at the conditions that are more prevalent and where the losses occur, if you look at it, depression, anxiety, and childhood behavior disorders, all of which are easily treatable conditions that cause loss of life and loss of productivity each year. So what are some of the solutions? And that's what I wanted to spend the majority of time talking about today. We have effective strategies for prevention and treatment of mental health conditions. We've had them for years. We have lots of data that supports their effectiveness in all kinds of settings. We know prevention works, and prevention is inexpensive. Prevention occurring in clinical sites in primary care, schools, other community settings have demonstrated effectiveness. We know that primary prevention in church communities and schools work, in places where kids are every day. We know that parenting interventions are available to prevent the onset of mental illnesses by protecting them from harsh parenting. And then for parents who have mental health conditions, we have treatments. There's psychotherapies that bring young people to remission, particularly for anxiety and depression, the two most commonly affecting young people. And we have pharmacotherapies and medications for pediatric mental health, not as many as we do for psychosocial interventions, but we have interventions that work. We also know that prevention is inexpensive and easy to do. So we know that kids, children, and families have protective factors. Coping skills bolster resilience and improves mental health. So positive physical development, emotional self-regulation, or ability to regulate your emotions, family structures with units, with limits and rules, monitoring and routines, academic achievements, safe schools, good coping skills, supportive relationships with family members, things that bolster self-esteem, things that bolster engagement in schools and communities, activities with peers, athletics, employment, religion, culture, and positive racial ethnic identification are all protective factors. They're positive coping skills, and they support resilience and improves mental health. And some of the things that we can do to accomplish those goals are easy. The enablers are education, learning, recreation, employment, social opportunities for people to be with other people, and not be marginalized or discriminated against, and maximizing protective factors in the environment, like safe parks and safe spaces for kids to be able to play. And all of these interventions can be tailored to the environments where kids live, so they don't require a special skill set to accomplish them. So we've had a lot of conversations in the last few years about fostering resilience as a preventive strategy to support mental health. But when we talk about resilience, most of the time, we're talking about individual qualities, right? The early conceptualizations were, it's a person's ability to bounce back from adversity and pick themselves up when they fail. And we always attributed this to either the individual or just their parents. And as you can see, the kid at the top, that's not the way to build resilience. But the contemporary conceptualization of resilience integrates culture, community, context, and resources. And so we conceptualize resilience for each person as a combination of systems that come together to support a child's ability to overcome adversity. We know that there are individual factors that determine one's response to stress. So there's biology, stress regulation, your immune system, your family relationships, your community, schools, resources, the political environment, and other economic determinants. So, it's important to recognize that fostering resilience is not a treatment for mental health. It's not a solution. It's a necessary component of achieving mental health. So what are some of our challenges? Well, as we just talked about depression and anxiety prior to the pandemic, we predicted that after the pandemic, we would see an increase in the rates of depression and anxiety. And then the estimates obtained in that first year suggested about 1 in 4 youth would be experiencing clinically significant depression, and 1 in 5 are experiencing clinically significant anxiety. And that's not insignificant. As I mentioned, symptoms can lead to impairment, and symptoms actually often impair function, even when they don't meet the criteria for a mental health disorder. We anticipate that there is going to be an increased demand for mental health services, and that's definitely what we're seeing in the United States. We saw 30% increases during the pandemic, and we continue to see increases now. Another factor that we know will impact the mental health of young people had to do with the number of caregivers who were lost during the pandemic. The estimates are that worldwide about 10 million young people lost caregivers during the pandemic. And we know that traumatic loss can lead to complicated bereavement, but it can also, which has been associated with depression and suicidality for adults. We also know that we have interventions and brief treatments that can change the course of that outcome for young people who have experienced traumatic loss. And it's also important to remember that with the COVID pandemic, children had a different type of loss. Frequently, they saw family members who were totally healthy the last time they saw them, who suddenly went off and never came back. And because of the restrictions, they were never able to adequately mourn the loss. So it's a very different kind of loss than at other times. So where are we now? I give you all the bad news, that some things seem to be worse, but actually it's a time of opportunity for us. We have a chance to actually change the course of children's mental health treatment. And right now, with the whole world watching, is the time for us to do that. UNICEF's statement, I think, is the call to action for us. We have a chance to commit, communicate, and take action to promote, protect, and care for the mental health of a generation. We can provide the support for a foundation of a generation equipped to pursue their dreams, reach their potential, and contribute to the world. And how can we do that? We can do that by thinking about the behavioral health continuum that's useful for psychiatric care. And that consists of low-level preventive opportunities like communities, schools, and primary care, to ambulatory clinics for kids who have lower acuity needs, to more intensive programs as we move up the continuum through a partial inpatient, outpatient program, emergency crisis, and inpatient. There's also opportunities to use telehealth as an enabler across all of these services. And there's also an opportunity to build more mobile crisis teams, people who can actually go to a home in the midst of a crisis and help the family stabilize their child. And then there's health promotion and prevention, which are all the things that we can do every day in our communities. One good example is school-based mental health, where schools frequently provide tiered levels of care. So there's school-based universal interventions that all kids get, which is teaching kids how to talk about their feelings, teaching kids to find reliable adults that they trust. And then there's early identification for kids who have behavioral health concerns or are at risk for behavioral health concerns. So if we know if a child's been abused, is abused in their home, it's an at-risk child. There are targeted school interventions for those at-risk students. And then there's students who have problems already. They may have developmental disabilities or other things. There's an opportunity to focus on supporting those kids in their school. Doesn't require intensive resources, except for the kids who actually need the most intensive resources. Another very useful intervention that some of you may be familiar with is called Project ECHO, which is an extension for community healthcare outcomes. ECHO moves knowledge, not patients. So they use an electronic platform, which is either a phone or a video, and they actually provide support and education for clinicians at the point of service. So for example, the patients get the right care at the right level. Maybe their diagnosis is ADHD. The provider acquires new knowledge through the ECHO platform, which could be a group of people who meet with the provider once a month to educate them about specific mental health diagnosis. They're able to treat more patients, and they can build a community of practice. It reduces disparities by keeping young people in their communities. They retain providers who develop their skills, and it keeps the patients local so they're not traveling for care. And when things go well with the ECHO program, it increases access, quality, and costs. Now, those are things that already exist, but we can do more. So the future for children's mental health is all of us finding innovative solutions that reduce the stigma, encourage young people to address their own needs, and to improve their well-being while expanding access to appropriate and timely care. So some of our opportunities Some of our opportunities include digital health, non-specialist providers, and peer support. So I just want to take a minute to define what we mean when we talk about digital health. So because it's a broad term. So digital health technologies usually use a computing platform or some kind of connectivity software and sensors for healthcare related uses. They span a wide range of applications and we've all used them in some capacity, but the goal is to use the platform to support healthcare. So there's mHealth or mobile health, which we all frequently use. There's the electronic health record. There's also wearable devices like our Apple Watch. Most of us have used telehealth and telemedicine and some personalized medicine where we use mobile devices to track physical measures for young people struggling with certain conditions. We're also all exposed to the medical application of artificial intelligence and machine learning, and they provide opportunities to improve health outcomes. They also provide opportunities to make health outcomes worse. But I think but overall, there's opportunities to use them to improve care. COVID has changed the landscape in many ways and provided us with some challenges, but some opportunities. So if most of us recall, we were unable to really utilize telehealth prior to the pandemic, but about 90% of the world's educational ministries implemented remote learning during the pandemic, but about a third of kids had no digital platform, so they couldn't really use it. We know that approximately 2 billion children under 25 years of age have limited or no internet access. And that is especially true for people who are living in poverty and girls. And then, as I mentioned before, there's a lot of concerns about the impact of social media and a lot of mental health concerns. Do they make anxiety, depression worse? We know that excessive screen time can interfere with normal activities like sleep, play, physical activity, school. There's the risk of cyberbullying and victimization. And then for vulnerable youth with mental health conditions, social media can have an adverse impact on their mental health and on their self-esteem. So there's an upside and a downside, but this is the landscape that we're dealing with right now. And I see many opportunities for improvement in healthcare. And I'll give you some examples. COVID has provided opportunities for us to expand access to mental health and psychosocial support services through telehealth. And we were allowed to actually move to those interventions relatively quickly. We were able to distribute educational materials much more easily using the telehealth or digital health platform. We're also able to use it for screening and diagnosis and treatment and care. And one of the best utilizations I've seen is training and supervision of mental health workers. It also allows us to track trends in human behavior, which can inform some of our interventions. And there's also an opportunity to bolster the global mental health workforce that will increase equity and access to care and increase resources. And we'll talk a little bit later about that. We also know that digital platforms are more acceptable to youth. So they'd rather use a digital platform many times than have a face-to-face office visit. They're much more likely to respond to mental health services, and we're finding that's true in the States. The services are much more, young people are much more open to using them if they're convenient, if they're self-paced, they can use them when they want, if they're anonymous at the initial contacts, if they don't use a lot of text, although they will text, and if there is an opportunity to connect with peers who have had similar experiences. Now, we learned in our own institution that digital platforms can exacerbate disparities. So, for example, at Boston Children's Hospital and Children's Hospital Philadelphia, we noticed that fewer minority patients use telehealth to access services in our clinic, and we're tracking that data to make improvements. UNICEF has established an innovation portfolio that I think has really informed practice for the rest of us. They recognize that young people are much more likely to use mental health services if they can do it independently from their phone. We also have opportunities to create more efficient first response systems in mental health care. So a phone line or a text line that responds to young people will allow them to more openly discuss a problem with a counselor or someone else. And then there's also an opportunity through the innovation portfolio to reduce disparities in distribution of mental health workers. And that's one of the most exciting components that I've seen of these digital health platforms. And I want to talk about one that I am especially excited about and participate with. So Vikram Patel at the Harvard School of Global Health has a program called Empower. And Empower provides an opportunity. It's an opportunity for major advances in mental health service due to key enablers. The key enablers are the digital platforms. So right now there's a call to action because of the global mental health crisis, and there's a tremendous amount of focus on expansion of care. We know that brief psychological interventions are effective, and there are thousands of them. We also know that most of those interventions never make it into the hands of clinicians. And so non-specialist providers can learn to use those interventions with fidelity if they're trained. And through digital supervision and supervisors, they deliver the training and they monitor the effectiveness and fidelity to treatment for community workers who are non-specialist providers. So these could be anyone who lives in the community, not a mental health professional, who actually can be educated using a digital platform and monitored with feedback for fidelity and outcomes. Another very effective intervention that's emerging is computerized modular evidence-based therapies. And we know that ECBT, or cognitive behavioral therapy delivered electronically, is effective for depression and anxiety. And it's moderately effective on its own. It's more effective with coupled with in-person therapy. And there are already existing digital products for youth that they can access freely. There are websites, games, apps, robotics, and virtual reality. We use virtual reality to teach individuals with autism how to behave when they meet a first responder. We also use virtual reality to teach the police officers and paramedics how to respond when they approach an autistic individual. And then there's mobile messaging that's commonly used for people to have conversations with counselors using a crisis line to address problems. There's also solid evidence to support some of the ECBT programs, like SPARKS is one of them. And SPARKS stands for Smart, Positive, Active, Realistic, X Factor. It's a CBT skills regulation program that teaches you emotional regulation, managing anxiety, and how to respond to the things that provoke anxiety for you using an avatar so people can walk through a modular game. And Sparks has been found to be moderately effective for treating depression and anxiety. We're also starting to use social media data sets to learn about at-risk populations. So for example, the social media technology provides opportunities for us to gather data, something that's called web scraping. And you're able to use the verbalizations or the messages that are posted to use algorithms to determine which kids might be at risk for suicide. And so currently Facebook is looking at how they can use users' posts to identify those who are at risk for suicide and other mental health conditions. And so there's lots of promise to how we can use some of these digital technologies. And so taken together, what is needed to improve the future of children's mental health? So first of all, it takes all of us, and it takes all of us, a diverse group of stakeholders, being committed to investments in children's mental health. We need to have shared goals and shared priorities. We need to provide more education to populations about mental health stigma and improve mental health literacy. And digital health can help us do that easily. We need to support more implementation science. So we all know that most of these studies never make it to the community. And so we need to support more studies that allow us to translate that knowledge into action. And then we need to partner with patients and families because they have to be partners in driving care delivery. We can't do it all ourselves. And then we have to invest in health promotion and prevention. It's cheap. It can be done in schools and communities, and it doesn't require a high level of skills. And we need to drive change to support mental health by using some of these creative interventions. Integrating mental health in healthcare settings, schools, child welfare, juvenile justice, churches, and other places, and preparing a workforce of non-professionals to be able to support this care. So what does a system of care that's effective look like for children? It looks like this: bringing the village to the children. It should be a youth-centered system of care enabled by primary care, schools, community, home-based care, emergency care when needed, juvenile justice, child welfare, behavioral health. The goals are to establish overall health and well-being for all kids. And then the medical and mental health professionals, digital health, and peer support are all enablers. And we can accomplish this because now is the time. And finally, I want to leave you with the words of Frederick Douglass, ex-slave, abolitionist, and scholar, it is definitely easier to build strong children than to repair broken men. Thank you.
Thank you, Professor Benton, for a very insightful talk on children's mental health future. We have Dr. Akasha with us. Professor Akasha is online and he's able to receive questions. So if anyone has any question.
Professor Kasha, two specific issues. One is that an Indian pharmaceutical company has come up with a drug called endoxifen. It's a PKC inhibitor derived from tamoxifen, used for both phases of the disorder, primarily for mania, for treatment of mania and hypomania. And it's quite effective, and we have about 2 years experience with it. It's a DGCI approved drug and currently undergoing trials by the FDA. The second input is that we are currently examining two issues in bipolar disorder, at least in the Indian subcontinent, based on studies by Judd and others, that we are finding difficulty in understanding the construct validity of hypomania. And we believe that the concept of bipolar 2 is a redundant concept. There's just one thing, it is a reverse of what Dr. Akiskal came about with, only bipolar 1. Because the bipolar 2 with a lot of antidepressants going in the patient, they would have mild periods of aggression which can be easily mistaken for hypomania. Second issue is that we are now reviewing the concept of using mood stabilizers for life in bipolars. If we look at the natural course of bipolar, the longitudinal study is done, and the current study is done, we feel that there are large periods of euthymia which exist with or without drugs. So if there is no family history of bipolar disorder, if there is a short duration of 1 or 2 episodes, 3 episodes of bipolar 1, depression of course with mania, then we are now reviewing the concept of using mood stabilizers for life.
Thank you very much for your kind comments. I'm not aware about the medication in India that is derived from tamoxifen, but I'll look it up and read about it. Regarding the concept of hypomania and bipolar 2, I think it's very important that we do not say that bipolar 2 does not exist, because bipolar 2 patients suffer more than bipolar 1 patients. Because according to the literature, bipolar 1 patients have 3 depressive episodes and 1 manic episodes, while bipolar 2 patients have 30 depressive episodes compared to 1 hypomanic episode. So that is to say that bipolar patients spend more time in depression than they spend in hypomania. So we have to derive methods in order to try as much as possible to detect hypomania. And during my presentation, we have the hypomania checklist, which was initiated by Jules Angst, and is translated into Arabic and validated into Arabic and has been published. And all people in the Arab world are allowed to use it, because people who have been misdiagnosed with unipolar mood disorder, nearly 70% of bipolar patients have been misdiagnosed as unipolar patients because they were not able to detect hypomania. We always had the Beck-Rafelson mania scale to detect, to see the severity of depression. We had the young mania scale, but we didn't have the hypomania checklist. Professor Jacob Akiskal had different views, because he said there's bipolar 1, 1.5, 2, 2.5, 3, 3.5, and so on until 4 and 5. So bipolarity is there. Regarding the use of mood stabilizers for life, especially in euthymic patients, it has been proved now that even bipolar patients during the euthymic phase have a cognitive deficit. similar to cognitive deficit that is in schizophrenia and that is in depression. So even if your patient is depressed or manic or hypomanic and euthymic, there is a cognitive deficit. In order not to write a mood stabilizer for a long time for a patient, it has to be a drug-induced episode. But if we have family history of bipolar, we have family history of substance abuse, comorbid, we have history of severe suicidal or psychotic depression in a bipolar patient, then I think the use of a mood stabilizer for at least 2 to 5 years after the last episode is important to try and protect the patient. Thank you very much for your comments.
We have one more question.
Thank you very much, Professor Okasha. It was nice for you to participate in this important meeting which is taking place in your region. I have got just one comment. You will be pleased to know that WPA, in collaboration with CINP and the World Federation of Biological Societies, we are planning to collect different guidelines published in different countries and especially in different regions. I will appreciate that at some stage if you would help us to give us any guidelines that has been developed in the Arab world, because that will be a good addition to the world literature that these three organizations are planning to jointly collaborate and compile.
Thank you, Professor Afzal Javed, for your comments. And let me take this opportunity to congratulate you, congratulate Dr. Medhat Sabahi on a wonderful conference and an excellent scientific program. We have guidelines in Egypt for the management of, from the Egyptian Psychiatric Association for the management of schizophrenia and treatment-resistant depression. We are currently working on the bipolar guidelines, and it will be very happy for us to join the World Federation of Biological Psychiatry and the WPA in presenting our guidelines. Thank you very much for your kind comments, sir.
So, yeah, I have one quick question for Professor Okasha. Are you an advocate of lifelong treatment for bipolar patients after the third episode? As in, do you think that after the third episode, they should remain on lifelong treatment, medication-wise?
I'm an advocate for patients receiving 2 to 5 years of mood stabilizer after their last episode. However, lifelong mood stabilizer treatment should be indicated in patients who have had previous suicidal attempts, strong family history of bipolar disorder, a family history of suicide, and comorbid substance abuse, which induces these episodes. And then lifelong is does not actually mean forever and ever. Lifelong in the literature usually talks about 5 to 10 years. In the Arab world, unfortunately, it is not very easy, because once the patient is euthymic, we have pressure as psychiatrists from the family of the patients asking us to trust or wean the medication in order to stop it. And even if they're on lithium, or they're on valproate or on carbamazepine, that ask to take half the dose. And we have to explain to them that there is a serum level that has to be maintained in order to prevent it. So aside of pressure from the family, we should continue for at least 2 to 5 years if it has more than 3 episodes of mood disorder. Other people around the world advocate for lifelong treatment in order to prevent the morbidity and mortality that can occur from bipolar disorder.
Thank you so much, Professor Okasha, and I'd like to thank all our 3 speakers for taking the effort and participating at our Congress, despite of inability to join in person. We'll have to skip the break for now, since we're over time, and the next session will start.